Good afternoon and welcome everyone to the Infectious Disease Epidemiology Seminar Series brought to you by the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health. I am Bradford Taylor and I will be your moderator for this session. I'm excited and honored to welcome Professor Michael White as our speaker today, who is at Institut Pasteur. So just a few standard logistics throughout the talk. You can send questions via the chat function to Loretta Magosi. And please specify if you would like to ask the question directly. We will ask you to turn on your camera and we'll unmute you once we are ready to take your question, if that's the case. Okay, now I will introduce Professor Michael White. Professor Michael White leads the Infectious Disease Epidemiology and Analytics G5 unit in the Department of Global Health at Institut Pasteur. His team uses interdisciplinary research tools spanning mathematical models, epidemiological cohort studies, and multiplex assays to investigate the epidemiology of infectious diseases. A key goal is the development of multiplex assays and statistical tools for integrated surveillance of multiple pathogens. Professor White has a particular fondness for malaria and neglected tropical diseases, but like many other researchers, he has also developed an interest in coronaviruses too. And he has contributed in the development of novel serological assays. Professor White's talk today is entitled Novel Diagnostics for Serological Surveillance and Treatment of Malaria. Thank you very much for joining us on this final talk for the seminar series. Please take it away.
Okay, thank you very much for that kind introduction. Today I'm going to talk to you about some of our work in the development of novel diagnostic tools for serological surveillance of malaria, in particular Plasmodium vivax malaria. So I'd like to start with my acknowledgement slides. Firstly, acknowledging the team here at Institut Pasteur. The work I'm going to show you today has arisen out of a collaboration when I was working with Ivo Muller in the Walter and Eliza Hall Institute in Melbourne, and together with Ivo and Rhea Longley and in Weihai, and also Takafumi Suboi in Ehime University in Japan, we developed a lot of the methods behind some of what I'm going to show you today. And another key collaborator in this project going forward will be Chris Drakeley from the London School of Hygiene and Tropical Medicine. But there's many other collaborators who I will talk about at a later stage. I'd also like to thank some of the funders. So my lab here is supported by the Inception and LabX IBEID grants here at Institut Pasteur, and we're also supported by the European Union and some support from the Bill and Melinda Gates Foundation. So I set up the Infectious Disease Epidemiology and Analytics unit at Institut Pasteur last year, and it reflects a little bit some of my past interests. So that started off with mathematical modeling and analytics while I was doing my PhD and postdoc at Imperial College London. Then when I worked with Ivo Muller in Weihai in Australia, gained more experience in field-based epidemiology, in particular with some studies in Papua New Guinea. And now with my time here at Institut Pasteur, we've started working a lot more with multiplex assays. And to do this, we use a range of different tools. So this includes mathematical models of population-based transmission, statistical methods to analyze antibody kinetics, clinical trials, the implementation of tools for serological surveillance, the implementation of epidemiological studies, and using multiplex assays. And the overall aim of our group is to apply interdisciplinary tools to develop diagnostics for multiple different infectious diseases. And just to give a very brief overview of a very simple overview of some of the ideas that we use for serological diagnostics. And a few key ideas are that antibody levels change over time and that we can get information from this. If we measure more types of antibodies, this can give us more information about a particular question. With one serological test, you can do many different applications. And finally, that we can integrate surveillance across multiple pathogens. So just to give a high-level overview of some of these ideas before going into the details, the first is that antibody levels change over time. So this is data from an individual in Thailand infected with Vivax clinical malaria, with Vivax malaria. And this person had a clinical episode and then they were followed up and sampled every 2 weeks, and antibody responses were measured. And I'll zoom in on one particular antibody response to a pathogen in detail. So this is the antibody response to Duffy binding protein. And we see a very distinct pattern with a rapid boost in antibodies following clinical malaria, followed by rapid decay in the first 3 months, and followed by a slower phase of decay thereafter. And this is a very classic pattern of boosting and rapid waning, followed by a second slower phase of waning that we see for antibodies to many different antigens for malaria. And it's also something that we see across multiple different pathogens, whether the antibodies are induced by natural infection or by vaccination. And this is with this very key kinetic pattern, it can tell us a lot about things like time since infection. The second idea is that if we measure more types of antibodies, then we can extract more information. And this is an example from some of our work on serological diagnosis of SARS-CoV-2 infection. So what we have here is nucleocapsid IgG antibodies on the x-axis, spike IgG antibodies on the y-axis. And this is in blue are samples from negative controls, and in red are individuals infected with the ancestral strains. And we can see that these separate out quite nicely. And if we want to do serological diagnosis, then we just draw a line. So if we're just working with spike IgG, then we draw this pink line. And if you're above that line, you get classified as positive. If you're below it, you get classified as negative. Quite straightforward, and it does a very good job. Alternatively, we could choose to do classification with nucleocapsid antibodies. In this case, we draw a vertical line. If you're to the right of it, you're positive. To the left of it, you're negative. And you can see this does a reasonably good job at separating these data points. Not quite as well as the spike antibody response, but it still does okay. The next thing we can do is maybe we can combine the signal from both of these antibody responses. And this basically requires drawing a bendy line. So basically we want to separate out these two clouds of positives and negatives. And this will give us some curved surface that is your classifier. And there's lots of things you can do to draw that line. You can do something as simple as a logistic regression, or you can use some slightly more sophisticated machine learning tools, such as a random forest or a support vector machine. And this is an example with just 2 antibodies, so it's nice and easy to visualize in 2 dimensions. But you can imagine that this gets slightly more complicated when you get more and more data. The next idea that we use is that if you have one test, then you can use the same test for multiple different applications. And again, I'm going to use some example from some of our SARS work just to give you the overview, and then we'll go back to malaria. But the overall idea in a lot of serological diagnostics is that you take a single blood sample and then you measure one aspect of the antibody response. For example, your spike IgG. You measure that antibody response, and then according to whether or not that's greater or less than some predefined threshold, that gets classified as positive or negative. An alternative approach is to not just measure one aspect of the antibody response, but to measure many different antibodies to many different antigens of different qualities of the antibody response. And then you can build up what you call a serological signature from a single blood sample. And then given this serological signature, we can then apply different statistical analyses or different algorithms to do different things. So we can do diagnosis of previous SARS-CoV-2 infection, as we had seen. We can do estimation of time since infection. How long ago were you infected? This will become important later for the malaria work. We can do confirmation of vaccination status, identify was somebody infected and vaccinated, or just vaccinated. We can study the immunity to seasonal coronaviruses. We can provide estimates of immune status, so identifying people who don't have many antibodies following vaccination and may need to be revaccinated. And we can do identification of variants. And then the last idea is that we can, using this sort of approach, we can also integrate surveillance across multiple pathogens. And we can do this because of the multiplexing technology that we use. So in this study, we use something called a Luminex MagPix machine, which is a bead-based multiplex assay where you get little magnetic beads and then you couple antigens onto them, and then they're all read with a laser. And this is a technology that we quite like because it can multiplex up to 50-plex. So we can measure 50 different types of antibodies in one sample. We can run it on 96 well plates and do it in a reasonably high throughput fashion. You need quite a small sample volume, so 1 microliter of serum or plasma will work very nicely. It works on a range of different sample types, so serum, plasma, saliva, or dried blood spots. And then you can implement different variations of the assay to measure IgG antibodies, IgM, IgA, and even factors such as the antibody avidity. So now I'm going to turn to some of our work on using some of these ideas to develop serological diagnostics for Plasmodium vivax malaria. So Plasmodium vivax malaria is probably less well known than the other dominant strain, which is Plasmodium falciparum. So this map shows the geographical distribution of where vivax malaria is. And you can see that it predominates in South America, the Indian subcontinent, and parts of Southeast Asia, and a lot of it in Papua New Guinea. You find some vivax in Africa, most notably in Ethiopia, Sudan, and Madagascar. But across the rest of Africa, there's little to no vivax malaria because most people of African origin have they're Duffy negative, so the parasites can't invade their red blood cells. And it's falciparum malaria that causes most of the cases in Africa. So maybe if you're a clinician, sometimes you might see vivax malaria in North America or in Europe. A typical case would be if you get somebody traveling around South America and then they come back to Paris or to Boston, and then 6 months later, after their holidays, they get a relapse. So they get malaria all of a sudden. And it's this relapsing behavior of vivax that is very interesting. So these parasites, which I'll show you in a moment, they can stay hidden in the liver and then relapse many months later. So looking at the phenomenon of relapses in a bit more detail. So the process begins with a bite from an infectious mosquito, which inoculates sporozoites into the skin. These sporozoites then travel to the liver within a few minutes, and some of these parasites undergo immediate development, leading to a blood stage infection a few days later. And this is the paradigm for falciparum malaria: 1 mosquito bite, 1 blood stage infection. But vivax is a little bit more interesting because some of these sporozoites will stay arrested in the liver and they'll hide in liver hepatocytes, and then they'll stay dormant for weeks, months, or years until they wake up and relapse to cause new blood stage infections. And this is the paradigm for vivax malaria: 1 mosquito bite, multiple different blood stage infections due to these relapsing hypnozoids. And the challenge of these hypnozoids is that they're really difficult to detect in the liver. They sit inside liver hepatocytes and they don't do much, and you can't detect them directly. So our approach is to do indirect detection. So rather than looking directly for those hypnozoites that are hiding in the liver, we can look at the initial blood stage infection that the mosquito bite caused. So this is the primary blood stage infection. And that blood stage infection will have induced an antibody response. And some of the antibody responses are short-lived, some have a medium duration, and some are long-lived. So we can then come along at a later date, take a blood sample, measure those antibodies, and then based on those measurements, we can identify individuals that have been recently infected. And here I'll define recently infected as maybe within the last 9 months. So then the hypothesis is that if we can identify people that have had a blood stage infection in the past 9 months, then these are the same individuals that are carrying these hypnozoites. And then if we can do that, then we can target them and identify them for better treatment. So in order to test out this hypothesis, Ivo Muller, who I work very closely with, implemented a number of longitudinal cohort studies in different areas of the world that are endemic for vivax malaria. So this included cohorts in Thailand, Brazil, and the Solomon Islands. And the study design is to go into a community where there's endemic transmission and prospectively recruit 1,000 healthy community members and follow them up for an entire year and take a blood sample every month. And then in all of these 1,000 people, we've done PCRs, so we can say when people were infected with malaria. So for example, this one individual would have had a 3-month infection between months 4, 5, and 6. The next thing we did was we looked at the final time point. And in the blood sample from that final time point, we measured the antibody response to 60 different vivax antigens. And then what we're interested in is the relationship between that measured antibody response and the time since the previous infection. So this individual was infected 6 months ago, but as we look across the cohort, we see a range of different behaviors, with some individuals with very recent infection, 2 months ago, some individuals with very old infections, and many individuals with no malaria infections at all. So what I did was develop a range of machine learning tools to select optimal combinations of these vivax antigens that can predict the time since previous infection. And we tested a large number of different antigens, and this was our best hit. It's the reticulocyte binding protein. So this is a protein that the vivax parasite uses to invade the young reticulocyte red blood cells. And this is an example of the data that we have. So I'll focus in on the data from Thailand. So this is the IgG antibody to RBP. And individuals that are infected had very high antibody levels. Individuals who were recently infected within the previous 9 months had high but slightly lower antibodies. Individuals with old infections, that's 9 to 12 months ago, had lower antibodies. And individuals who we didn't detect any infections over a year had lower antibodies again. And this is a pattern that's repeated again in Brazil and in the Solomon Islands and is consistent with data from negative controls. So the simplest algorithm that we can do for identifying recently infected people is just draw a line. So if you're above that, you get classified as having a recent infection. And if you're below it, you get classified as having an old infection. And what we can do then is we can characterize how well all of our 60 different antigens do at classifying recent infections using receiver operating characteristic curve as shown here. Now this characterizes the trade-off between sensitivity on the y-axis and specificity on the x-axis. And here you can see how our best hit, which is the reticulocyte binding protein, stands out from the pack a little bit. Now the next question is, okay, that is single antigens. Can we do better by combining antigens? And the answer is yes. If we integrate together more antigens, we get better classification performance. But all of these antibody data are very correlated, so we do hit a challenge of diminishing returns. Adding in additional antigens will allow us to do better classification, but it's not going to go all the way. And in total, with 5 antigens, we can get about 80% sensitivity and 80% specificity. Now, a perfect diagnostic test would be up here in this right corner, but that's something that's quite hard to do when we're trying to accurately time infections. So to date, we've been using our MagPix assay in the lab to do all of this work. And we're working with a partner in Australia to develop this into a point of care based test so that we can take this out of the lab and into the field. And the reason that we want to do this is we have a very particular application in mind. And this is something that we call Plasmodium vivax serological testing and treatment. And I'll illustrate this with this example here, where these individuals, you can consider them to be a population that live under natural exposure to Plasmodium vivax. And here we have some of them infected with blood stage parasites, and some of them, a higher proportion, in fact, infected with parasites in their liver. Now, in order to target the parasites in this population, you've got two strategies. One is wait for people to get sick and then target them when they come into the clinic. But there's a huge amount of asymptomatic transmission, so that's not going to work very well in this scenario. The other strategy is to go to the population in an intervention and target malaria transmission in the community. So your first option is to do something called mass drug administration. So that is, you just give drugs out to every single person that needs them. And the drug for treating these parasites is primaquine, which I'll talk about more in a moment. And then everybody's targeted. So everybody that needs to be treated is effectively treated, but you're giving drugs to a lot of people that don't need them. So there's a lot of individuals there that are not infected and they're being overtreated. So primaquine overtreatment is a big problem. Another strategy is something called mass screen and treat, where individuals are tested with a blood stage diagnostic. So this is something like a rapid antigen test for picking up malaria antigens of parasites in the blood, or microscopy. And this is called mass screen and treat. So you go out and then you diagnose the individuals, and then you'll pick up the majority of the individuals that have blood stage parasites, but you will completely miss all of those individuals that have parasites in their liver. So here, the people that need to be treated, you're missing a lot of them. So the effective treatment is quite low because the people with parasites in their liver are untouched. But it's quite a conservative strategy. You're not giving out a lot of drugs. The alternative strategy that we want to do is do serological diagnostics of individuals with parasites in their liver. So if we have a diagnostic test with 80% sensitivity and 80% specificity, then we can diagnose individuals that need to be treated, and then we can provide treatment. So here we would have 80% of the people that need to be effectively treated are treated, but as the test isn't perfect, there is still a small degree of overtreatment. So that's the idea that we want to build with this intervention. So in order to investigate this in more detail, something that I did a lot of work on was developing mathematical models of how Vivax diagnostics and treatment are implemented. So I'm going to focus in here in a little bit more detail on how you treat these Vivax relapses, because this is useful to understand. So again, the process has begun with a bite from an infectious mosquito, which inoculates these parasites into the liver, and then people will have blood stage infections. Some of these blood stage infections will give you symptoms, and typically in most cases where there is Vivax malaria, when you get symptoms, the person is given chloroquine or an artemisinin combination therapy. And these drugs are very useful because they will cure you of your symptoms. They will eliminate all of the red blood cells of the malaria parasites from your bloodstream, and you'll feel a lot better. But drugs such as chloroquine leave the parasites in the liver completely untouched. So these will just reactivate weeks or months later, and the person will be infected and possibly even sick again. The alternative, so for Vivax, what you need to do is you need to give a combination of drugs such as chloroquine and primaquine. So the chloroquine will knock out the parasites in the blood stage. You can also use an ACT. There's a range of different drugs that you can use for this. And then the primaquine will eliminate the drugs for the liver. The challenge is that primaquine is a difficult and dangerous drug to use, and there's a risk of severe hemolysis in patients with a G6PD deficiency, which I'll go into in a little bit more detail in a moment. So it's tempting to think of Vivax treatment as it's just like falciparum, where you need to treat the blood stages, plus the problem of relapses, where you need to give primaquine to hit these parasites in the liver. But it's a little bit more complicated than that. And that's because Vivax is a complex parasite. And because I've been living in France now for a few years, when I think of complexity, I think of an onion. So I think of Plasmodium vivax malaria as like an onion where the parasite itself has layers of complexity. So the first layer of complexity is these relapses, which we've spoken about. Then we can peel away another layer of the onion and we can think about, okay, these relapses are caused by hypnozoites, and then these hypnozoites need to be treated with special drugs, such as primaquine, and there's other drugs called tefenaquine, which I'm not going to go into today. But a big problem with this drug called primaquine is it can trigger hemolysis in G6PD deficiency. Now, G6PD deficiency is an inherited blood disorder present in about 5 to 10% of the population in areas where you typically have malaria. And if somebody's G6PD deficient and you give them primaquine, then their red blood cells will hemolyze and they will get very sick. So this means that primaquine is not an easy drug to use, and you don't want to just be throwing it out everywhere. You then have other even more complex problems, such as the fact that G6PD deficiency is X-linked, so it shows up differently in males and females. You have problems of age and pregnancy restrictions. If you go down a further level, you've got interactions with metabolization, which I won't go into for the detail. And then you have other factors, such as, is there resistance? Are there interactions with falciparum? Are there unknown factors? So there's all these layers of complexity that need to be taken into account when thinking about how to treat Plasmodium vivax malaria. And if we had what's called a single dose radical cure with no restrictions, this would just cut through all of that complexity and we wouldn't have to worry about it. So by a single dose radical cure, I mean a drug that you can give one dose, no problem, it cures it knocks out all parasites, then that would be perfect. But such a drug does not exist. So we have to come back and deal with all of these complexities. So our approach to dealing with these complexities is to incorporate all of this into a mathematical model. So I'll start again with, I'll go back to some of the very basics, which are a Ross-McDonald model of malaria transmission. And these have historically been described for falciparum malaria. And the approach is basically just to classify individuals into compartments according to whether or not they have blood stage infection. So susceptible or infected. And then individuals move from susceptible to infected according to the force of infection from mosquitoes, and then they recover at some rate. And these Ross-McDonald models have been really well described for about 100 years now. They're one of the very first mathematical models used for any pathogen. But these models are not appropriate for vivax malaria because of the extra parasites that stay hidden in the liver. So these can be extended to account for liver stage infection. And now here, this is done using the superscript. So 0 denoting no liver stage infection, and the superscript 1 denoting liver stage infection. So these individuals are blood stage positive with or without hypnozoites, and these individuals are hypnozoid positive with or without hypnozoites. And then by looking at the transitions between these compartments, we can build up essentially the basic ingredients of what you need for vivax transmission. So you need mosquito infection, and we assume that every mosquito bite will give you a primary blood stage infection plus hypnozoites. So everybody moves to the bottom right-hand corner. We have the issue of relapses, where people with hypnozoites in their liver can relapse and have a new blood stage infection. We have clearance of blood stage infection, where blood stage infections are cleared out. And we also have clearance of hypnozoites. And of course, because this is malaria, then we also have to have mosquitoes. And this is quite a simple system, compartmental system. So we can do very nice things like write down differential equations, calculate values of R0, and do lots of interesting theoretical work. But this is a very basic model of vivax transmission, and it leaves out a lot of the critical details. So subsequent to this theoretical work, we have also developed much more complicated models of vivax transmission. And in particular, these are bigger individual-based stochastic models that account for age structure, heterogeneity in exposure, immunity, entomology, incorporate different interventions, and account for all of the relapses. And these are something that we've fitted using MCMC to a wide range of different data sets. And the advantage of this sort of model is it allows us to make much more detailed simulations of the impact of different interventions. So today, the intervention that we're most interested in is this PV serotype intervention. And this is, and the question that we want to look at is, can we use models to help us better design our diagnostic tests? So here I'm going to move back to that receiver operating characteristic curve that I was showing you earlier. And this shows us our diagnostic test. And with our diagnostic test, we can basically choose a test that lies anywhere along this ROC curve. These are values of sensitivity and specificity that are available to us. So we could choose a PV serotype intervention with very high sensitivity. So basically, if people have hypnozoites, we're very likely to target them and treat them, but we're going to pay a price in terms of specificity. So we'll have a lot of false positives, and we'll give drugs to a lot of people that don't need them. Alternatively, we could choose an intervention with high specificity. So that's a safer intervention where we're really only giving the drug to the people that we think really need it. But there's a big trade-off there in terms of sensitivity. Alternatively, we could choose a balanced intervention where we're saying, okay, we don't know which we want. Do we want to optimize specificity or sensitivity? And it's not obvious which one of these we should go for. So we can investigate this in mathematical models. And we can also compare with some of the pre-existing interventions. So for example, if we were to do a mass drug administration, so instead of doing our diagnostic test, we just give drugs to everybody. That's very sensitive because our criteria is we just give the drugs, but it's got very poor specificity, huge overtreatment. Alternatively, we could do a mass screen and treat with a blood stage diagnostic test, but that's going to have very poor sensitivity. So what we did next was to compare these three strategies using our mathematical models. And we did this across a very wide range of scenarios, varying transmission intensity, the treatment regimens, the number of rounds. There's too many panels here to look at in detail, so I'll zoom in on one in particular. And here we can see this is a diagnostic test with 80% sensitivity and 80% specificity. The green line is if we did 2 rounds of mass screen and treat, and we can see this is very little impact. And we don't expect this to have impact because it leaves the liver untouched. The red is if we did mass drug administration, so basically gave Primaquine to everybody in the population. And this is the maximum impact that you can have. But you can see that the blue curves are if we did PV serotype with 80% sensitivity and specificity. And while it's not as good as just giving drugs to absolutely everybody, and it can't be, it still has nearly as big an effect size. And not shown here, we can also explore how varying the sensitivity and specificity will impact the outcome. And the summary of this is, if we have greater diagnostic sensitivity, then we have greater impact. So it's higher sensitivity means you're targeting more people and you're going to reduce malaria. Whereas if we choose to optimize greater diagnostic specificity, that gives a safer intervention. So that will give you less overall impact, but you're giving out fewer drugs to people that don't need it. And actually, how to balance these off is not something that a model alone will tell you, but it's got to depend on other external factors, such as the acceptable risk to the population. And we also see the very expected findings that more intervention rounds will give you greater impact. And the effect size is also going to be dependent on transmission intensity. So these were reasonably theoretical simulations. The next thing we started doing was to simulate the designs of different clinical trials. So this is a simulation of what PV serotat would look like in a clinical trial. And here we're assuming 2 rounds of PV serotat and following up for some period of time. So in red, you can see that this would give us quite a substantial reduction in PCR prevalence of vivax. And this is in a more real life situation where there's also some seasonality in transmission. And doing these simulations have allowed us to do some theoretical optimization of what we think a trial design should look like and how should we design these trials. So following this more theoretical work, my collaborator, Chris Drakely, and I applied to Horizon Europe to launch a clinical trials program. And we were recently awarded a grant of €8 million to test out this diagnostic test in large cluster randomized trials. And this brings together a lot of different expertise from my team here in Institut Pasteur. So we're contributing expertise in diagnostics, mathematical modeling, and epidemiology. We also have anthropologists here at Institut Pasteur because the human side of this is very important. For example, they can address how do you balance the need between a safer intervention where you don't give primaquine versus the need for a more riskier intervention that might have a bigger community level impact. In the London School, Chris Drakely is providing his expertise in clinical trials and in serological assays. And then our partners in Africa are the Institut Pasteur de Madagascar, where we'll have one clinical trial site, and the Armauer Hansen Research Institute in Ethiopia, where we'll have a second site. And then we also have experts from the University of Galway in Ireland who have expertise in mobile health technology. So there's going to be some digital infrastructure around the implementation of this study, and experts from the Foundation for Innovative New Diagnostics in Switzerland, who will provide expertise in diagnostics development and translation. So this trial will have 2 sites, as I described, in Ethiopia and Madagascar. It'll be a 2-arm trial with the control arm, of course, and 1 arm receiving PV serotat. In total, we'll have 48 clusters with 12 clusters per arm across the 2 sites. And we'll have 400 participants per cluster that will be targeted. So these will be self-contained contiguous transmission units of villages. So all in all, we'll have nearly 20,000 participants enrolled in the study. And we'll do 2 intervention rounds and 24 months of follow-up. And we start in October. So we're starting to get everything ramped up to translate a lot of this work that started off with lab-based optimization of antigens, development of computational algorithms, and testing it out in the field. Okay, so I'm going to finish with some future research directions and what we're doing to expand this sort of approach from P-Vivax to other pathogens. So my lab have recently invested in a new machine. This is something called an XMAP IntelliFlex. It's the new generation machine from Luminex. So it goes beyond the MagPix and it can multiplex up to 500 plex. So in a single sample, we can measure antibodies to 500 different antigens. We can run 96 and 384 plates. And it's quite cool because there's a dual reader system that has with an extra laser that allows us to actually measure more things from one sample. So most previous assays could only measure IgG. And if you wanted to measure IgM, you've got to run the plate again a second time. But this allows us to combine 2 different assays in the one plate, which is quite neat. And we're continuing to do some work on classification algorithms and antibody kinetics and some applications for surveillance models and developing analytic tools to look at cross-reactivity. So one of the things that we're doing is expanding out to look at multiple pathogens, going beyond parasites. So to date, most of our work has been very malaria focused, ended up doing a lot of coronaviruses, like many other people, not planned. And we've, in collaboration with the CDC, we're doing some work on neglected tropical diseases. And we're in the process of expanding out this approach to look at tick-borne diseases, arboviruses, and leptospirosis. And then over the coming years, we'll also look at respiratory pathogens and vaccine-preventable diseases. The idea being that we can use this technology to measure antibodies to multiple different antigens from different pathogens in the same sample. And so this is the lab-based technology, but in order to really, for this to be really useful, it's very dependent on the access to having appropriate samples. And again, to do this, we use the same study design as before. So the core study design that we use is taking 1,000 healthy participants and follow them for 1 year. And in the NIH ISOMER, the International Center of Excellence in Malaria Research, we've been involved in running a few of these cohorts in Cambodia, Papua New Guinea, and Ethiopia. These longitudinal cohorts have been implemented in Cambodia. This is a picture of the Cambodian study team, and we do all of the data collection using digital surveillance and data collection, so it makes it quite efficient. And I'm in the process of launching a fourth one of these cohorts in Senegal, where it's the same study design, but we're going to collect stool samples as well. And then the idea, and I'm doing this with Dr. Mokhtar Niang in Institut Pasteur at Dakar. And then the idea is that in every single sample, we'll measure all of the IgG antibodies so that we can look at kinetics. We'll test for malaria and other pathogens such as lymphatic filariasis. And then we'll look in the stool for a range of different intestinal parasites. And we're in the process of setting up multiplex PCR assays for looking in stool samples. And these sorts of cohorts will give us lots of great samples and the right sort of information so that we can really look at the kinetics for a wide range of different pathogens. And I will finish there because I think I'm at 40 minutes and leave my acknowledgement slide up. And I'm happy to take any questions that you may have. Thank you very much.
Awesome. Thank you very much for this terrific talk, Professor White. We will now take questions. We will try our best to accommodate as many as we can. However, if your question does not get covered, please feel free to reach out to our speaker directly. Remember, submit your questions to Lorado via the chat function. Okay. Yeah, so I know that I might kick it off. I have some questions in there, maybe coming from a naive perspective, but I'm really interested with sort of differences with maybe human response to hypnozoites. And so you mentioned, for example, that certain genetic loci are associated with issues with treatment. Does that also kind of reflect differences in disease outcomes or maybe variation in hypnozoite amounts or maybe threat to individuals? Is there any sort of connection there?
Yes, so the key one is probably G6PD deficiency, which is very present in a lot of populations that have malaria. And it's a real pain if you're trying to give them Primaquine. But it's not a coincidence that it's there. It's there in those populations because it also confers a degree of protection against clinical malaria. So that's against the clinical symptoms. Whether or not it has an impact on the individual hypnozoite, I don't know, and I don't know if anybody knows. But for malaria, there's a huge number of genetic markers that have impacts on different factors. Mostly it's on clinical malaria. I don't know if anything has a direct impact on the hypnozoites, but it may well be the case.
It's news to me, so I'm fairly naive with this, so I appreciate that. I guess similarly, when you were looking at some of the antibody responses, like the waning, like for instance with the reticulate binding, I believe. I thought I noticed some differences kind of between countries in terms of the waning, but maybe that was just something I didn't see. Do you have any sense of whether or not there are differences between the countries that you guys looked at, and whether or not that could be more of what would the origin would that be? Would that be sort of sampling or maybe demographics or something like that?
Yeah, excellent question. So it's important to look at different countries because the first main factor is transmission intensity. So if you go in somewhere really high transmission intensity, then people have very high levels of baseline immunity, and this is going to be harder to do. So people's baselines are higher in the high transmission setting. So this really works better in lower transmission settings where you're going for elimination. So it's very easy to tell somebody that's infected or not if some in a population that has no background. So transmission intensity is a very important factor. Genetic variation is also very important. So these are antigens that are based on particular constructs, and I can't remember the exact reference genome, but they're going to be an antigen that might work well in one geographic area won't necessarily work very well in another area.
Gotcha.
So it's important that you look in multiple places. And that's something that even we did a comparative study in Brazil and Peru, which are not that far away. And I think, and one antigen worked very nicely in Brazil, but not in Peru. That's one of the advantages of having the fallback of having the multiplex approach, where you're not relying on just one thing.
Absolutely. Yeah, that makes sense. And I guess that's so for a classifier perspective is that becomes very important to kind of have a specific model for each country, I guess, to maybe avoid that. Let me see what else we have. Okay. Let's see. I'm going to also open the floor if there's individuals who want to just raise their hand and ask any questions. We have a moment. I see that James Hay has raised their hand. James, would you like to unmute? And yeah, perfect.
Sure. Hey, Michael, good to see you.
Hey, James.
So I have two questions, both kind of vague and just interested to hear some of your discussion. So the first is that the antibody kinetics figures you showed, particularly at the start, are quite stylized. It's quite like, have nice boosting, nice waning, and it's pretty consistent. So the question is, well, two-pronged question. One is, how much variation do you see across individuals? And do you ever see kind of additional unexpected, say like boosting events or unusual kind of peaks and troughs in titer? So for the Vivax specifically, and also, across the pathogens that you mentioned at the end.
Yeah, excellent question. And you're absolutely right that it's stylized, and that's also for the, it's because of the more general audience, but I know you know this data very well, and the reality is it's a lot less tidy. So I could show you hundreds and thousands of other plots where it's not so clear. So the first thing is you get huge variation. So it'll vary by orders of magnitude. So when you're looking at the magnitude of the response, that'll vary over a log scale. You get noisiness in the kinetics. So even on one individual, some kinetics might fall right down and some might be very slow. So so you get variation in how high up it goes, you have variation in the rate it comes back down, and that varies between antigens, between individuals, and in every way that you can think about. You also have background assay measurements, so sometimes you just see things that are noisy, and you also have other phenomena that we don't really know what's going on. So a lot of the time when you look at the kinetics, you see, oh yeah, it looks exactly like what's happened, and then it boosts for some reason that you don't know. That could be an undetected infection. It could be cross-reactivity with something we're not looking for. A lot of the time you see things like if you get vaccinated, if you're measuring, say, tetanus antibodies, which is a really nice control, and then if you get malaria, you'll see a boost in your tetanus. And that shouldn't be the case, but what's happening is it gives a short-term polyclonal activation to lots of random stuff. So you get a little boost. So there's all sorts of these random sources of noise that we really don't have a clue about. We know it's only a small fraction about it.
And the kind of implications of that. I mean, this is a horrible question, but how much of that complexity do you think is important to consider when doing inference? I mean, you kind of showed the simplest approach, which is you draw a line, you say you're seropositive, you're seronegative. And then, as you know, the stuff I've done in the past is very much like you have a kind of population mean titer trajectory and you infer your time since infection based on that. Do you think there are some kind of good rules, or like what are your thoughts on the kind of future of the methods in terms of what level of complexity of that with that variation do you need to start accounting for?
Yeah. So a lot of this variation can be explained. So age, you get a lot of signal out from age. Gender, nice, easy things to do. So if you're building like a classifier, putting age and gender can be very useful. There's a lot of other factors which are undoubtedly important, like going down into the HLA genotypes, but they're not feasible to measure in practice. So I put that in the bag of unknown variation, and you're probably never going to be able to get at it in any feasible way. So our approach is just to get big enough data sets that we can at least quantify the uncertainty, and then we can apportion it out to what we can explain and what we can't explain. And roughly speaking, we can probably explain about 60% of the variation. But yeah, I'm not going to put a number on that. It depends very much on your application and what does it mean to explain variation. But there's some of it we can explain, some we can't.
So I do have another question, but I maybe kind of cede to other people first.
Sure, we have a couple more questions, so maybe we'll move to those and then we can come back to you, James, if there's time. First, there is, I see a hand, but I will get to one of the questions that was asked prior to that, and then we'll move on to the hand. So Angela Early wants to thank you for a great talk, first off. In your future directions, she asks, are you planning on looking at interactions between different infecting parasites and pathogens? And so what are your thoughts on, I guess, those interactions? Maybe, I'm not sure if that's specifically on cross-reactivity or more generally, but so yeah.
Yes, so interactions are very interesting. You have interactions on the biological level, which we're not going to touch because that's complicated stuff about interactions. One thing that we can definitely pick out is interactions on the epidemiological level. A lot of the time, what's easy to do is you just see certain things clustering together. So what we have the statistical power to do is look at kind of interactions on that epidemiological level. So for example, we often see the same people infected with Vivax and falciparum. We started also screening for different neglected tropical diseases, and we see huge overlap between Cryptosporidium and Giardia and other intestinal parasites. So you see different things clustering together on an epidemiological level. So yes, we're looking at interactions that way. Cross-reactivity is definitely really important. You've got cross-reactivity between things you're measuring. So if you're measuring two things and they're cross-reacting, you can see it. You've also got cross-reactivity between things. You might be measuring one and not measuring the other, and that's kind of, that's your known unknowns sort of scenario. That's kind of hard to deal with. And then some of them, the cross-reactivity challenge is really wicked, like in arboviruses, where you've got so much similarity that that's a challenge that I think we're going to be picking over for quite a while.
Gotcha. Cool. And then I saw that Dan Neepsey had his hand. Yes, perfect. Thank you.
Hey, Michael, great talk. I was interested in your remark that you seem to see an impact of allelic variation even between locations as proximal as Peru and Brazil. I wonder if you have any plans or thoughts about like exploiting that phenomenon to, for example, distinguish locally transmitted versus imported cases.
Yeah, good question. So my remark there was based on measured antibody responses to PV Syrpa, CYRPA. Now I cannot remember what that is, what it stands for, but we got beautiful responses in Brazil, and it just didn't really work in Peru, which is not very far away. Whereas the other pathogens that we looked at, we got everything else was exactly as expected. What we've not done, and this is much to my shame, is look at the sequences of malaria parasites commonly found at both of those locations. I think the reason it's kind of hard is if we did look at the sequence, and then we could look at how the sequence of the parasites matches to the sequence of the antigen that we used, we could see something, but these are very noisy and very cross-reactive. So I think it could be possible to do, but you've got huge levels of cross-reactivity to pin it back one to the other. So I think possible in theory. I don't think it's something that we're going to try. For some cleaner systems like COVID, you can do it, where you're just looking at the RBD of an Omicron versus Delta, and then you can see how that matches through to the type of antibodies. But I think malaria is a much more complicated beast, and I'm not quite sure I'd be able to do it.
Great, thank you.
Cool. And I think we have time for one last question, James, if you want to sneak that in.
I think it was already actually answered in the question after mine, so no problem. Thanks.
Oh, okay, cool. Awesome. Well, I think we are basically at the top of the hour. So on behalf of the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health, let's thank Professor White again for joining us today and for a fantastic talk and discussion. Please get in touch with any of the seminar organizers if you have further questions for a speaker. As a reminder, this is our last seminar in our ID-EPI seminar series this year. So please check out the CCDD website to stay up to date on upcoming seminars and other events. Thank you again for joining us. Bye, everyone.
Thank you very much. Thank you for the invitation.